Mr. R is 64-year-old man with a history of hypertension and stable angina. Visits his GP complaining of knee pain. The GP wants to choose an NSAID that is least likely to increase his cardiovascular risk. Which of the following NSAIDs is the most appropriate to prescribe? A, B, C, D, or E? Well done, guys. Naproxen is the correct answer. Okay? Naproxen has a low risk of cardiovascular events, cardiovascular side effects. Which other NSAID also has a low risk of cardiovascular events aside naproxen? What's the next best answer after naproxen? Ibuprofen. Okay, so naproxen has a low risk of cardiovascular side effects. Ibuprofen also has a low risk. But the reason why ibuprofen is not the most appropriate answer in this question is the dose. Okay, ibuprofen is best when the dose is low, 400 milligram TDS, that's 1.2 gram. Okay, so for this question, naproxen is the right answer. What NSAID has the highest risk of thrombotic events? What NSAID has the highest risk of thrombotic events? Diclofenac. Diclofenac has a high risk of thrombotic events. High strength of ibuprofen as well. Okay. Even COX-2 selective inhibitors as well also have high risk of thrombotic events. So basically, what you need to know for your exams, if you get the question, the patient has cardiovascular comorbidities like this Mr. R, okay, you should be looking at an NSAID that has the lowest risk of cardiovascular side effects. In this case, it's naproxen. Ibuprofen would also be an appropriate option if the dose is low dose ibuprofen of 1.2 gram or less. Okay, so before we move to the next question, what NSAIDs can NSAIDs be used in pregnancy? Can NSAIDs be used in pregnancy? Most NSAIDs are not safe in pregnancy, okay? What about breastfeeding? Can ibuprofen be used in breastfeeding? Patients who are breastfeeding. Yeah, so ibuprofen can be used in pregnancy, not really recommended. Ibuprofen can be used in breastfeeding, not really recommended in pregnancy, okay? However, it says that you should avoid using first and second trimesters unless essential. So you should definitely avoid ibuprofen in third trimester. So generally, I would not recommend ibuprofen in pregnancy. Paracetamol is what is recommended as an analgesic in pregnancy. Okay. However, ibuprofen can be used in breastfeeding. How about codeine and dihydrocodeine? So codeine and dihydrocodeine, which is recommended in patients who are breastfeeding? No, not OTC, generally. Is dihydrocodeine safe in breastfeeding? Yes, well done, well done, well done. There's, yeah, it's recently been changed. Okay, so dihydrocodeine can be used in patients who are breastfeeding. Okay, at the moment. However, codeine should not be used. It should be used with caution, but it can be used in patients who are breastfeeding. NSAIDs and alcohol. What's the interaction between NSAIDs and alcohol? NSAIDs and alcohol. What's the interaction? Increased risk of bleeding. Thanks, Samira and Hussein. Okay, increased risk of bleeding. NSAIDs and alcohol. What about NSAIDs and ACEIs, ACE inhibitors? NSAIDs and ACE inhibitors. What organ is going to be affected? Is it the kidney or the liver? The arteries of the kidney. Okay. So before you move to the next question, quick recap. Gastrointestinal events, ibuprofen low dose has the lowest side effects. Okay, low dose of ibuprofen is safe in patients who are at high risk of gastrointestinal events. Naproxen has an intermediate risk. Okay. However, for cardiovascular events, naproxen and ibuprofen are the preferred options. In this case, naproxen is preferred to ibuprofen because of the dose. This is 400 milligram QDS, that's over 1.2 gram. So this patient is best using naproxen 500 milligram twice daily. Next question. So I've got option A. Most people have gone for option A, edoxaban 30 milligram once daily for the treatment of deep vein thrombosis. Okay. So what's the standard dose for DVT treatment with edoxaban? What's the standard dose for treatment of DVT? And when do we consider dose reduction? What's the standard dose and when do we consider dose reduction? So the standard dose is 60 milligram once daily, like Pierre has stated, okay? 60 milligram once daily. But if the patient meets one of three criteria, then we need to consider dose reduction. So what are those three criteria that requires dose reduction? The weights, okay? So I've got 60 kg, If the patient, okay, what else aside the weights? If the patient is on certain medications, P-glycoprotein inhibitors. Okay, if the patient is on certain medications like cyclosporine, aside cyclosporine, what else? Yeah, so we've got cyclosporine, dronedarone, erythromycin, and ketoconazole. So cyclosporine, dronedarone, erythromycin, and ketoconazole. So if the patient is on any of these four medications, that's a criteria for dose reduction from 60 milligram once daily to 30 milligram once daily. Okay, so I've got creatinine clearance as well. If the patient's creatinine clearance is reduced, what creatinine clearance are we looking at to consider dose reduction? What's value? Creatinine clearance 15 to 50. Yes, less than 50. Okay, so between 15 to 50, then we need to reduce the dose from 60 milligram once daily to 30 milligram once daily. And finally, the patient's, yeah, so that's it. The patient's weight, the patient's creatinine clearance, and if the patient is on any of these three medications, CDEC, cyclosporine, dronedarone, erythromycin, and ketoconazole. So the dose will need to be reduced from 60 milligram once daily to 30 milligram once daily. Okay, so what criteria did this patient meet? The weight, right? The weight is 59 kg. So for that reason, we need to reduce the dose. So option A is the right answer. Edoxaban 30 milligram. All right. So we've got 30 milligram once daily, twice daily, three times daily, once daily, twice daily. Now, in terms of doses of DOACs, what DOACs are once daily and which ones are twice daily? So aside edoxaban, which other DOAC is once daily? Apixaban can be given once daily. Is that true or false? Apixaban can be given once daily. Is that true or false? False, yes. So apixaban is twice daily. Okay. Rivaroxaban can be either twice daily or once daily, while dabigatran is twice daily. So we've got apixaban and dabigatran twice daily. Well done to everyone. Edoxaban is once daily. So really, edoxaban is the only one that must be given once a day. So if you get a question in the exam and you see twice daily, three times daily, that automatically disqualifies that option. Okay, it should definitely be given once daily. So for this question, dose reduction, um, that's what this question is trying to test you on. So for the treatment of DVT with edoxaban, the patient would require 5 days of parenteral anticoagulation with low molecular weight heparin. Does this apply to all anticoagulants? Does it apply to all DOACs? So which ones require low molecular weight heparin first? Yeah, so basically your rivaroxaban and your apixaban, they have a rapid onset of action. So we don't need to start with a low molecular weight heparin. Okay? rivaroxaban and apixaban. So patients starting rivaroxaban and apixaban for treatment of DVT will just start it. Okay, however, for edoxaban and dabigatran, you would require, yes, you would require um, treatment with low molecular weight heparin before starting the anticoagulant. All right, I've got another question. Mr. D, a 78-year-old man weighing 61 kg, has recently been diagnosed with non-valvular atrial fibrillation. You're asked to recommend the most appropriate apixaban dose for Mr. D. His serum creatinine is 120. Which of the following dose is most appropriate for him? So I've got option E, I've got option C. Which is most appropriate for him? 5 milligram BD of apixaban. That's correct. Okay. So for apixaban, we said apixaban is always twice daily. Should always be twice daily. Okay. So for apixaban, the patient needs to meet two of certain criteria, two of three criteria for dose reduction. Okay. So what are the three criteria? When do we reduce the dose to 2.5 milligram BD? What's the first one? So we've got A, B, C. A is for age. So from what age do we consider dose reduction in patients on apixaban? Yes, if the patient's age is over 80. Remember that as patients increase in age, they are at high risk of side effects with anticoagulant, drugs, bleeding, renal impairment, and the rest. So age over 80 is one. The second criteria is B. B is for body weight. So body weight less than 60 kg. And finally, we've got C. C is for creatinine clearance. If the serum creatinine, if the serum creatinine is 133 and above. So A, B, C of apixaban. A for age, B for body weight, and C for serum creatinine. If the patient meets two of these three criteria, then they would require dose reduction from 5 milligram twice daily to 2.5 milligram twice daily. I hope that's clear. So that's for patients who have non-valvular atrial fibrillation for stroke prophylaxis. What's the dose of apixaban for treatment of DVT? What's the dose of apixaban for treatment of DVT? Remember, for treatment of DVT, the dose is usually higher than stroke prophylaxis. Okay, because the patient actually has a DVT. So we are trying to give the highest dose possible to reduce the patient's risk to reduce the patient's risk of coming down with mortality due to the venous thromboembolism. So for patients who have got DVT, the dose is going to be higher than the regular 5 milligram BD. So someone said 10 milligram BD for 7 days. I think James said that. That's correct. So 10 milligram BD for 7 days. Initially, you want to give a very high dose, and then for maintenance, we're going to give 5 milligram twice daily. Okay, so 10 milligram daily for 7 days, then 5 milligram twice daily. That's the dose of apixaban for treatment of DVT. Okay, so when it comes to your DOACs, you might need to learn a couple of doses for your exams because you might get 1 or 2 questions. So for apixaban, for example, like I said, 5 milligram BD is standard dose for stroke prophylaxis in non-valvular atrial fibrillation. Okay, dose reduction is required if the patient meets any of these criteria. Sorry, two of these criteria, A, B, C. A is for age, over 80 years, B is for body weight, less than 60 kg, and C is for creatinine, greater than 133. That's for stroke prophylaxis. However, for treatment of DVT, the patient actually has a DVT, so we need to give a higher dose. So we're going to give 10 milligram twice daily for the first 7 days, and then 5 milligram BD. So how long would the patient need to be using the medication for? How long are we going to give treatment for 5 milligram BD? How long would the treatment last for if the patient is trying to, in terms of maintenance treatment for deep venous thromboembolism? So what's the duration of therapy? That's my question. What's the duration of therapy for patients with DVT? Okay. So Temi said 3 months. Any other attempts? Yeah, so it all depends on what caused the DVT, if it's provoked or if it's unprovoked. Okay? If it's provoked, you can give the patient treatment for 3 months, maintenance treatment for 3 months and stop. But if it's unprovoked, you want to give for more than 3 months, okay? And 6 months for cancer. That's correct. So I hope this has helped everyone to understand anticoagulants, drugs, especially for treatment. So duration depends on if it's provoked or if it's unprovoked. Okay. So standard dose of apixaban 5 milligram BD. Dose is reduced to 2.5 milligram twice daily if the patient meets any two of these criteria. Next question. Mr. R, a 79-year-old woman recently diagnosed with atrial fibrillation, has been started on apixaban for stroke prevention. When collecting her prescription, she asks you for information about her new medication. Which of the following statements is most appropriate to tell her? A, B, C, D, or E? If you've got an answer, please type it in the chat box. Which of the following is most appropriate? Yes, option D is correct. Okay. Antidote for dabigatran is idarucizumab. So let's look at the options together. Option A says dabigatran is generally better tolerated than apixaban in patients who experience indigestion. That's false. What drug has the most likelihood of causing dyspepsia? Which one has dyspepsia as the side effects? Is it apixaban, dabigatran, edoxaban? Which of them causes dyspepsia? Yes, correct. Dabigatran causes dyspepsia. So how do you counsel patients? How should dabigatran be taken? How should it be taken? Can it be crushed? So basically, one of the cautionary labels for dabigatran is that the medication should be swallowed whole. Do not chew or crush, okay? The medication should be swallowed whole. Do not true or crush. That's one of the cautionary labels for dabigatran. So this option B says apixaban and edoxaban inhibits factor 2A. What DOAC inhibits thrombin? Which of them inhibits thrombin? Which of them is a direct thrombin inhibitor? Dabigatran, yes, that's correct. Okay. So option C is obviously wrong because patients taking DOACs should avoid green leafy vegetables. That's false. That applies to warfarin, not DOACs. And even with warfarin, you don't necessarily tell patients to avoid. You just tell them to avoid drastic changes in their diets, especially green leafy vegetables. Okay. Option E, patients on apixaban should have regular INR checks. That's false. That applies to warfarin, not DOACs. Okay, so I've got another question on my screen. Mrs. B, a 45-year-old woman, has been prescribed warfarin for VTE. What is the recommended duration of anticoagulation? A VTE is thought to be caused by long-term use of combined oral contraceptive. Three months. Yeah, remember we said provoked DVT treatment, duration of treatment is 3 months. So quick recap on DVT. What are the other possible causes of DVT? So we've got combined oral contraceptive. What are the other possible causes of DVT aside contraceptive? HRT, okay? Immobility. What else? Pregnancy, long flights, surgery. Those are causes. Those are possible causes of venous thromboembolism. Obesity. Well done. Well done, everyone that's attempted. These are possible causes of venous thromboembolism. Okay. All right, so let's quickly do a true or false with these questions. Question one says that dabigatran capsules can be chewed or opened. Is that true or false? False. Remember we said that dabigatran can cause dyspepsia, so patients should swallow whole. Okay, so that's false. Number two, drugs are generally preferred over warfarin for patients who have difficulty maintaining a stable INR. That's true. Okay, so with drugs we don't require INR testing, so drugs are preferred. All strengths of rivaroxaban can be taken with or without food. Number three, is that true or false? All strengths of rivaroxaban can be taken with or without food. Is false. So what strength of rivaroxaban requires to be taken with food? What strength of rivaroxaban should be taken with food? 15 and 20 milligram. Thanks, Temi and Park and Jane. Okay, so number three is false. Number four, rivaroxaban can be used in dose administration aids. Is that true or false? Number four. Rivaroxaban can be used in dose administration aids. Is that true or false? It's true. Which which of the DOACs cannot be used in dosage boxes? Which of the DOACs cannot be used in dosage boxes? Dabigatran. So a few things you should remember about dabigatran. It shouldn't be used in dosage boxes. It shouldn't be chewed or crushed. It should be swallowed whole. It can cause dyspepsia. So D for dyspepsia, D for dabigatran, D for dosette, not to be used in dosette boxes. Okay. So number 5 says drugs require INR monitoring. That is false, obviously. Warfarin is what requires INR monitoring, not drugs. Number 6, currently there are specific reversal agents for all drugs. Is that true? So which drug doesn't have a reversal agent? Which drug doesn't have a reversal agent? Edoxaban, yes. So edoxaban doesn't have a reversal agent. So number 7 says apixaban and rivaroxaban do not require any specific dietary instructions or restrictions. Is number 7 true or false? Number 7 is true, yes. Warfarin is the anticoagulant that requires dietary restrictions. Drugs are fine to use regardless of diets. So number 8 says drugs are contraindicated in patients with mechanical heart valves. Is that true or false? Can drugs be used in patients with mechanical heart valves or not? It's true. Is it true or false? It's true, yes. So DOACs are used for non-valvular atrial fibrillation for stroke prophylaxis in patients with non-valvular atrial fibrillation. So it should really not be used in patients with mechanical heart valve. So what anticoagulant would you use if a patient has mechanical heart valve? Warfarin. Well done, Glory, and well done, Pack. Number 9 says DOACs have a rapid onset of action compared to warfarin. Is that true or false? Which has Drugs have a rapid onset of action compared to warfarin. Is that true or false? True. How long does warfarin take to kick in? How long does warfarin take to kick in? What's the onset of action of warfarin? 48 to 72 hours. So you can see that it takes quite a long time to kick in. Okay. So drugs have a rapid onset of action compared to warfarin. So which of the anticoagulants have the fastest onset of action? What class of anticoagulants has the fastest onset of action? Which ones? Is it your DOACs? Is it the parenteral anticoagulants or is it warfarin? So the parenteral anticoagulants have a faster onset of action compared to the DOACs. Okay. However, DOACs have a faster onset of action compared to warfarin. Okay. So number 10 says DOACs are effective for the prevention of stroke in patients with atrial fibrillation, regardless of whether they have valvular heart disease. Number 10. Regardless of if they have valvular heart disease. Number 10. Remember we said DOACs are for non-valvular patients. So the answer to that question is false. Okay? So if you get a question in the exam and the patient has a mechanical heart valve, warfarin is preferred. So this question is false. Number 11, apixaban has a twice daily dosing regardless of the indication. Apixaban has a twice daily dosing schedule regardless of the indication. Number 11, apixaban has a twice daily. Yes, it's true. Apixaban is BD. Okay? Apixaban is BD. Edoxaban is once daily. Apixaban is BD. Alright, I've got another question on my screen. Mr. K, a 52-year-old man, presents with central chest pain radiating to the left arm and jaw, which resolves at rest. He's currently taking paracetamol, metformin, and salbutamol. Which of the following medications would be the most appropriate first-line lung therapy for his angina? A, B, C, D, or E? First-line lung therapy, long-term therapy for his angina, A, B, C, D, or E? So what's first line for treatment of angina? And what kind of angina does this patient have? Is it stable or unstable angina? What kind of angina does this patient have? So remember, the difference between stable and unstable angina is the fact that stable angina resolves at rest. Okay, it occurs due to exertion. So this is stable angina. So treatment of stable angina, first line treatment options. What class of drugs are your first line treatment options for stable angina? So this is stable. The reason why it's stable is because the question says it resolves at rest. So it's stable angina. So Hussein said GTN spray, then beta blockers, and then rate limiting calcium channel blockers. Okay. So basically, GTN spray is for symptomatic relief. If the patient has chest pain, okay, GTN spray can be used at that time to help with symptomatic relief. Okay. But in terms of long-term management, we've got beta blockers as first line, and then calcium channel blockers. Okay, so beta blockers and calcium channel blockers. Beta blockers, if the patient needs an additional therapy, you can add calcium channel blockers. Or beta blockers, if the patient doesn't tolerate beta blockers, then you can switch to calcium channel blockers. Okay, and obviously your rate limiting calcium channel blockers are preferred because of their effect on the hearts. So what's the best option for this question? Is it A, B, C, D, or E? You need to consider the patient's medications. Yes, diltiazem is most appropriate. Okay, the patient has got asthma, so you will not want to recommend a beta blocker because the patient has got asthma. Patient is on salbutamol, so diltiazem is most appropriate. Okay. So aside beta blockers and calcium channel blockers, what other class of medications or what other medications are used for the management of stable angina? Yeah, Glory said beta blockers is not appropriate in asthma. That's correct. That's why. So always look at the context of the question. Okay, don't just jump to choose an option. This patient is on salbutamol, so we would rather give a calcium channel blocker. So long-acting nitrates, okay? Like which one? Which nitrate is long-acting? Isosorbide, okay? Yes, so isosorbide mononitrates, ivabradine, nicorandil, ranolazine, those are other options for the management of stable angina. Okay, so out of all these options, which of them could cause mouth ulcers? Which of them has mouth ulcers as a common side effect? Mucosal ulceration, which of them? Does anyone know? Yeah, so motion said nicorandil, that's correct. Nicorandil can cause serious skin, mucosal, and eye ulcerations, including gastrointestinal ulcers. And this may progress to perforation. So patients will need to stop treatments if that happens. Okay, so that's what's looking out for. A patient on nicorandil presents with mouth ulcers. You're not going to give any medication over the counter. You would want to recommend that the patient is referred. Okay, so which of them causes headache as a common side effect? Which of them causes headache as a common side effect? Yes, your nitrates. Okay. No, you can refer to GP. You can refer to GP. So which of these beta blockers are water soluble? Atenolol, okay? Atenolol is water soluble. What of bisoprolol? Yes, so can celiprolol, atenolol, nadolol, and sotalol. Those are examples of water soluble beta blockers. And what side effect is common to water soluble beta blockers? What side effect is common to water soluble beta blockers? Or which side effect is less common to water soluble beta blockers? So they are less likely to cause nightmares, okay, and sleep disturbances. They are less likely to cause nightmares and sleep disturbances. So remember, they are less likely because they are water soluble. They do not cross the blood-brain barrier, okay? So just to be clear, water soluble beta blockers are less likely to cause nightmares and sleep disturbances. Celiprolol, atenolol, nadolol, and sotalol are examples of water soluble beta blockers. All right, I've got another question about a 17-year-old patient recently diagnosed with hypothyroidism. She's been prescribed levothyroxine 25 micrograms once daily. She asks how and when she should take her tablets. Which of the following is the most appropriate advice? Which of the following is the most appropriate advice in terms of levothyroxine? Yes, option D. Well done, well done, well done, guys. You guys are doing really great. So, levothyroxine should be given 30 to 60 minutes before food, caffeine, and other medication. So, 30 to 60 minutes, that's what remembering for levothyroxine. Okay, 30 to 60 minutes. What's the timeline for levothyroxine if a patient needs to take, say, calcium carbonate tablets? How long how long do they need to wait before taking their calcium tablets? Levothyroxine and calcium. How long do patients need to wait? So I've got 4 hours from Temi and 4 hours from Jane and 4 hours from Pierre. That's correct. So 4 hours apart. So levothyroxine and calcium spaced 4 hours apart. Okay. For other medications, 30 to 60 minutes before other medications, food and caffeine. What about for iron? What about for iron? So I've got 4 hours as well for iron in the BNF. So I'm not sure if SPC says something different, but for iron and calcium, it says you should wait 4 hours. Okay. So both iron and calcium actually says 4 hours in the BNF. Both iron and calcium actually says 4 hours in the BNF. You can have a look at your BNF. But the most important thing is that you should know that those two medications interact with each other. All right. So let's levothyroxine is used for hypothyroidism. Okay. So patients that have hypothyroidism, what would you expect with their hormones? Thyroid stimulating hormone, will it be elevated or will it be low? What would you expect with TSH in patients with hypothyroidism? Yes, we're going to have high TSH, right? And we're going to have reduced T3 and T4. So high TSH and low T3 and T4 with hypothyroidism. And it's the opposite with hyperthyroidism. All right, so let's quickly look at these symptoms and then you can tell me if it's hypo or hyperthyroidism. Fatigue and weight gain. Fatigue and weight gain. Is it hypo or hyperthyroidism? Hypothyroidism. That's correct. Hypothyroidism causes weight gain and causes fatigue. Palpitations and tremor. Hyperthyroidism. Okay. Heat intolerance and diarrhea. Heat intolerance and diarrhea. Hyperthyroidism. That's correct. Okay. And finally, cold intolerance and constipation. Hypo. Yes. Okay, so cold, tired, and slow. Think hypo. Cold, tired, and slow. Think hypothyroidism. Hot, anxious, and fast. So fast is with regards palpitations and tremor, tachycardia really. While slow is with regards the patient has fatigue. So the patient is slow. So cold, tired, and slow for hypothyroidism. Hot, anxious, and fast for hyperthyroidism. Okay, this is the final question, and then we'll call it a day for today. Mr. K, an 85-year-old woman, was admitted after a fall. She's confused and dizzy. She's on these medications. Which medication combination is most likely to cause hyponatremia? Yes, option D. Well done, well done, well done. Citalopram is an SSRI. In previous sessions, we've said it over and over again that SSRIs cause hyponatremia. Benzoflumethiazide is a thiazide-like diuretic which also causes hyponatremia. Okay, so we said with hyponatremia, we mentioned three C's of hyponatremia. We said, what are the three C's of hyponatremia in terms of side effects? So one of it is confusion. Thank you, Aisha. We mentioned convulsions, and the last one is coma. Okay, but obviously this has if the hyponatremia is really severe, mild cases of hyponatremia might just cause nausea, um, vomiting, dizziness. Those are side effects to expect with low sodium levels in the blood. It could be caused by SSRIs. It could be caused by thiazide diuretics. What other class of medications would you see hyponatremia occur with? Which ones? What other CNS medications? Desmopressin, yes. Thank you, Hussein. Which other one? Yes, carbamazepine. Anti-epileptics like carbamazepine and oxcarbazepine can cause hyponatremia. Even your loop diuretics, not just thiazide, like loop diuretics can also cause hyponatremia. Okay. Will steroid cause hypo or hypernatremia? So for now, ureas, okay? Will steroid cause hypo or hypernatremia? Yes, steroids will cause hypernatremia and hypokalemia, and it would also cause high blood pressure. Okay, so that is all for today. I don't want to take so much of your time. So this is the last question for today. Let me know how you found the session. Was the session useful? Okay. Okay, so well done everyone. Please like this video and subscribe to the channel if you found the session useful. I plan to have an intensive revision course like I've always had. I had it in June and I've always had it whenever the exams are close. So I hope everyone is on the WhatsApp group. I would put more information on the WhatsApp group so that everyone can prepare. It's just going to be clinicals, a couple of days, probably 5 days. We're going to run through all the topics for a couple of hours. So yeah, I'll announce on the group, but just get ready. Probably next weekend we're going to start that. Okay, so please like this video, subscribe to the channel as well because I'm going to help you guys. I'm going to post more videos before your exams. So subscribe to the channel so that you would know when the videos are posted. Thank you guys for joining and have a good night rest. It's going to be a couple of days, yes, about 5 days. That's the plan. Okay.